Hi, I'm Monica Wills Silva. I am a principal advisor at the Behavioural Insights team in our international programs team, where I co-lead our work in low and middle income countries from our London office. Behavioural science is a fundamental part of what we do. We try and introduce a more realistic, evidence-based model of human behaviour into the design of policies and programs. And we do this also by trying to understand the context where the behaviour is happening, try and understand the sort of local population, their needs, their priorities. We do this by introducing qualitative research and doing in-depth formative phases. And we also complement all of this by trying to build as much rigorous evidence as we can through very robust quantitative research methodologies. This allows us to understand what works and, importantly, also what doesn't work. At a more personal level, the importance and the interest in behavioral science comes from my childhood. I grew up in Bogota, Colombia in the 90s, which at the time was one of the most dangerous cities in the world. And here comes this mayor with this sort of quirky alternative approach to public policy to introduce policies that better reflected our behavior, our norms, and that ultimately started to change people's behaviors and lives. Fast forward to my master's in public policy, I took a class called Governing by Ideas, where we were studying alternative approaches to public policy, one of which was the Behavioural Insights team, behavioral science, and how it could be applied to improve policies. But also we saw this anecdotal case of Antanas Mocos in Bogota in the 90s, and I just brought it together for me, and that's where I realized that this was something that I had seen worked in my life and that I just wanted to bring to others and to other places in my work. One of the projects that I think really illustrates the impact that these approaches can have is a project that we did with UNDP in Moldova. Moldova is a country that has one of the highest tuberculosis rates in Europe. Even today, and even though we have a treatment, around 1.5 million people die of tuberculosis, largely because a few of them did not complete their treatments. And so we were working with UNDP in that case to see whether there was something that we could do to help some of the tuberculosis patients achieve or complete their treatments and address some of the barriers that they were facing. And so in Moldova, like in many places, they follow the WHO guidance, which is a directly observed treatment, which means that you've got to go to a clinic and be observed by a medical practitioner, taking your medication to make sure that you're doing it well, which, as you can imagine, brings in all sorts of barriers, right? You've got to make sure you're arranging for someone to look after your children if you've got children. You need to make sure you've got time to go every day to a clinic. There's also a lot of stigma around being identified as a tuberculosis patient. And so this is some of the barriers that people were facing to complete their treatments. In order to address them, we designed an intervention which was basically a video observed treatment. Patients would record themselves following a very strict protocol where they would be interacting with a specific medical practitioner. We saw an increase in 40% in adherence with the medication, which is roughly the same rate that we see in other places in Europe, like in the UK. We take programs that are already there and try and create interventions that are not largely disruptive, but that are working with the sort of programs that are already in place. We try and do small modifications that reflect this understanding of human behavior that we have from the literature. And also we try and incorporate these sort of insights that we gather from the qualitative work to make them as impactful as possible. El Salvador and Honduras have some of the highest gender-based violence and femicide rates in the world. We were working with the Inter-American Development Bank to see if there was anything we could do to get women survivors of violence closer to some of the services that the government had created for them, to some of the helplines. In order to do this, we first did a qualitative phase so that we could gather as many insights as possible on how the services were being communicated, what sort of touch points we had with the women, the barriers they were facing, how they were feeling about the services as well. Through that work, we identified things like, for instance, women were displaying what in behavioral sciences we call uncertainty aversion, which basically means that we are more comfortable with known risks than with unknown risks. And we feel quite uncomfortable when there's some uncertainty laying behind the next steps. So in the case specifically of women, they were worried about more long-term things like what would happen to their children or whether or not they would have a place to live. But also they were worried about very specific things about the call, like who would pick up the phone, how long would it take, what will they ask me? How will this information be treated? Will they try and come and find me? So they were quite worried about the sort of interaction they were going to have with the service providers. And so one of the interventions that we created was addressing that bias specifically. So it was telling women what they could expect from the interaction with the services. And we also told them how their information would be handled, that it was all confidential, that if they wanted, it could be anonymous as well. Initially, we were going to test this intervention on the ground, and this was before the pandemic. But as soon as the pandemic hit, we had to move very quickly to make sure that we were able to reach women where they were, because we were worried that they were going to be trapped in lockdowns with their perpetrators with no information on what the helplines were. So we decided to test this online on Facebook. We created a number of ads and we tested different ads to see how many women we could get through to a page that had all of the information on the helplines and then to actually access those helplines. We found that the intervention that addressed uncertainty aversion increased the probability of women actually getting to that information by 20%. And so now this information has informed a national campaign that the Honduras government has created for TV and radio well beyond the Facebook app and the reach of those as well. Where it comes to working in development context, there's quite a few things we've learned over the years. The formative phase is extremely important because we can never assume that because something works elsewhere is necessarily going to work in a different context or a different country. So as much as we like bringing in the evidence, we always try to adapt that evidence to what we perceived and are able to capture from the context through qualitative work. So it's always important to take that into account, try and understand the local needs of the partners we're working with. We've also recently started testing some of the underlying assumptions behind some of the evidence that we're bringing in. When it comes to behavioral sciences, quite a bit of the research that underlies some of these biases comes from what we sometimes call weird countries, which is Western, industrialized, educated, rich, and democratic. And usually from lab experiments with university students who are not really representatives of the population we are working with in some of these development context. And so one of the things that we're trying to do, and we did recently in Malaysia, was to try and test some of these biases, try and see, for instance, if in financial decision-making, people were actually displaying things like present bias, whether that was affecting how they were making decisions in the long term. And so we're trying to do a little bit more of this when we come in. We also have learned that building very strong partnerships with local partners is very important, and that this is a collaborative process whereby it's not only us bringing this knowledge in to build these interventions, but it's also us coming in to learn from them as much as we can, and to try and learn about the sort of programs that they have in place, as I said before, but the norms and the culture around those programs as well, to make sure that it's well represented when you're designing these interventions. One of our first projects in a low and middle income country was actually a project with UNICEF in Mexico, where we were trying to look at whether we could improve maternal health outcomes through a behavioral science intervention. And in that case specifically, working with their platform Rapid Pro, trying to create or give the opportunity to women to give feedback to the clinics, give feedback to the medical practitioners on how their appointments were going. And we also were giving them information on what they could expect in the appointment. So know that they're going to measure your blood pressure, for instance, within the text messages. We also created an intervention arm or a variation of the treatment whereby women could access community health workers easily through a group of messaging. And since then, our partnership with UNICEF has only grown. At the moment, we're working on one of the most present challenges we're all facing, which is vaccination uptake. Specifically, we're trying to see whether we can encourage caregivers to make sure they're completing the vaccination scheme of children in North Macedonia and Georgia. And in that case specifically, we are looking at some of the barriers that parents face. So for instance, one of the things that we found is that they don't really get constant reminders in a systematic way that allows them to know when the next vaccination is coming up. And they also have a lot of fears around side effects, the likelihood of side effects. So we've created a number of interventions to address those two issues, reminders as well as side effects fears. And we're now testing them in the ground in 7 European countries. One of the things in my work that drives me the most, beyond the impact of a discrete trial or intervention, which is obviously always stimulating and interesting, is also how we work with partners to make sure that we're leaving something lasting behind. So regardless of the project we're working on, regardless of the policy area or who we're working with, there's always a very important element of capacity building that we incorporate into how we work with partners. And that can be a discrete workshop to just teach them how to apply behavioral sciences, generally to public policy or a specific policy area, or a large-scale program of work where we do a learning by doing process with partners on multiple years, multiple trials, to make sure that we can leave some of that capacity behind. And it's very, very stimulating when you work with civil servants or with staff in third sector organizations, and you see them increasingly questioning the data they're using, thinking about the data differently, being more empirically minded, being more willing to be proven wrong and more willing to test things, as well as trying to incorporate this sort of evidence-based understanding of human behavior into the design of policies that they're doing.